Pelvic organ prolapse is defined as the descent of one or more of the anterior vaginal wall, posterior vaginal wall, uterus or vaginal vault. Although not usually life-threatening, there may be significant impact on quality of life as it can affect daily activities, reduce self-esteem, and affect relationships. Normal pelvic anatomy and support. The pelvic floor supports the abdominal and pelvic organs and comprises of pubococcyges, iliococcyges, coccyges. The pubococcyges and iliococcyges forms the levator ani, and both muscles together with the coccyges forms the pelvic diaphragm. It is innervated by the pudendal nerve, S2, 3 and 4, in which damage during vaginal birth can cause pelvic organ prolapse and urinary incontinence. The pubocervical fascia and rectovaginal septum. The pubocervical fascia is a thickening of the endopelvic fascia anteriorly that supports the anterior compartment, specifically the bladder or urethra. It is a continuation of the abdominal transversalis fascia and is attached 1. Superiorly to the symphysis pubis, 2. Inferiorly to the cervix, and 3. Laterally to the white line, also known as arcus tendinous fascia pelvis. A defect of the pubocervical fascia can result in an anterior compartment prolapse or cystocele. The rectovaginal septum is a thickening of the endopelvic fascia posteriorly that supports the posterior compartment, namely the rectum or pouch of Douglas. It is attached 1. Superiorly to the pouch of Douglas and uterosacral ligaments, inferiorly to the perineal body, and 3. Laterally to the white line. A defect of the rectovaginal septum can result in a posterior compartment prolapse or rectocele and or enterocele. There are few types of pelvic organ prolapse. 1. Anterior compartment, cystocele. 2. Apical prolapse, uterus or vaginal cuff after hysterectomy. 3. Posterior compartment, rectocele. 4. Pouch of Douglas, enterocele. The etiology and risk factors of pelvic organ prolapse are congenital, such as collagen deficiency, pregnancy and childbirth, aging, obesity, menopause, and chronically increased intra-abdominal pressures, including chronic cough, constipation, heavy lifting. Symptoms of pelvic organ prolapse include the following: lump at introitus, pain, pressure, discomfort or backache, difficulty in walking, sitting or sexual intercourse, urinary symptoms such as urgency, frequency, incontinence, voiding difficulty, bowel symptoms such as constipation or difficulty defecating. Some may need to manually press on their rectocele to defecate, and vaginal discharge or bleeding. Physical signs of pelvic organ prolapse include cystocele. In severe cases, kinking of ureters can occur, resulting in hydroureters or hydronephrosis with impairment of renal function. Uterine or vaginal vault prolapse. Procedentia, where uterine fundus is palpable vaginally. Abrasion, ulceration or edema. Vaginal discharge or bleeding. Atrophic genitalia. Poor pelvic floor tone and or high post-void residual urine, which can cause recurrent urinary tract infections, urosepsis, hydroureters or hydronephrosis with impairment of renal function. Grading or staging of pelvic organ prolapse. The figure shows different pelvic prolapse grading systems. Quantitative pelvic organ prolapse examination system is the most commonly used. Quantitative pelvic organ prolapse examination uses a hymenal ring as a reference point, where structures above the hymenal ring are measured in negative centimeters, while structures at the level of hymenal ring is measured as 0 centimeter, and structures prolapsing below hymenal ring are measured in positive centimeters. Examination is performed during straining. Quantitative pelvic organ prolapse examination system comprises of 6 sites, with 2 each on the anterior and posterior vaginal walls and apex. 3 measurements are taken, 2 externally and the total vaginal length. Staging of pelvic organ prolapse. There are 4 stages of pelvic organ prolapse. Stage 0. A healthy pelvic anatomy will have no descent of organs during straining. Stage 1. Leading edge of the prolapse does not descend below 1 centimeter above hymenal ring. Stage 2. Leading edge of the prolapse is between 1 centimeter above and 1 centimeter below hymenal ring. Stage 3. Leading edge of prolapse is more than 1 centimeter below hymenal ring, but not beyond total vaginal length of -2 centimeters. Stage 4. Leading edge of prolapse is more than total vaginal length of -2 centimeters. Investigations for pelvic organ prolapse depends on patient's symptoms and may include cervical screening like pap smear or HPV screen, pelvic ultrasound, ultrasound of kidneys, ureter and bladder in cases of advanced pelvic organ prolapse, endometrial biopsy, urinalysis and or urodynamic studies if associated urinary symptoms. Management of pelvic organ prolapse depends on patient's symptoms and quality of life. Conservative treatment includes 1. Pelvic floor exercises, Kegel. 2. Topical vaginal estrogen cream. 3. Vaginal pessaries of different shapes and sizes. This is suitable for patients who are not keen or unfit for surgery, such as elderly or frail patients. Let us take a closer look at the ring pessary and gel horn pessary and where they will be positioned. Patients using vaginal pessaries require regular reviews every 4 monthly. Complications of usage include pessary fallout, discomfort, erosions, ulcerations, discharge, bleeding or infection. Surgical treatment. Surgery is site-specific and can be considered if conservative management fails and or patient is keen for it. Surgical treatment can be divided into 1. Reconstructive and 2. Obliterative. Reconstructive surgery. The category and severity of pelvic organ prolapse will determine the type of surgery for reconstruction. Anterior repair or colporrhaphy is conducted for anterior compartment prolapse cases. For apical compartment prolapse, vaginal approach through sacrospinous ligament fixation, or laparoscopic or open abdominal approach through sacrocolpopexy is conducted to fix the vaginal cuff. Vaginal hysterectomy and McCall's cultoplasty with or without sacrospinous ligament fixation is conducted for the reconstruction of the uterus for severe prolapse. Manchester repair is a vaginal approach procedure deployed only for elongated cervix. In posterior compartment prolapse cases, these are the types of surgery that could be conducted. Posterior repair or posterior colporrhaphy and anterocell repair are conducted. Mesh-augmented surgery, where a synthetic permanent mesh is implanted to augment pelvic organ support, is usually reserved for severe or recurrent pelvic organ prolapse and only used by trained urogynecologists due to associated mesh-related risks. Obliterative surgery. Colpoclasis can be considered for frail and medically unfit patients who are no longer sexually active. Complications of surgery include anesthesia or surgery-related complications. Example, injury to surrounding structures, bleeding or hematoma, infection and/or venous thromboembolism, VTE. Recurrence of pelvic organ prolapse due to poor native tissue support or persistence of pre-existing risk factors may also occur. Thank you for watching this video. This video is presented by Yonglu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.